نهلة محمد جديد ونهلة
ايوه موجوده هي.
نهلة محمد جديد.
اوكي she's in. she's in now. Okay, Dr. Nahla Zaki. Okay, we are on YouTube live and Kobe.
Assalamu alaikum.
Alaikum salam, and thank you very much for coming.
عليكم السلام.
عايزة العناوين.
Just one second please. 1 second please. 1 second please. One second.
Unmute دكتور وليد شبل.
Okay, one sec. Okay, I think Dara, are you zooming on Facebook? Okay, just 1 second because there's something. Okay, 1 second. Okay. I think we can go ahead now. Go ahead, Dr. Nahla.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Welcome everyone to our meeting tonight, which I think it's the 21st episode of this online mega anesthesia course. My name is Nahla Awad, and I'm so honored to be your moderator for tonight. Inshallah, we will have useful and resourceful night as always. First of all, I would like to thank Dr. Saad Mahdi and his team, the founder of this interesting and so useful course for all anesthesia practitioners in Egypt and in the Middle East. Tonight, we will have 3 lectures as you know, as it is always the case. And the questions will be answered at the end of the 3rd lecture, inshallah. Have our professor Samir Al-Ansari, who is the professor of intensive care in Ain Shams University. It's an honor to present Professor Ansari. For my generation, he was one name for all of us to look up to. Although I haven't met him in person, but his effect in all of us is great. My professor, please go ahead and start. Thank you.
Thank you, Surah. Good evening. Good evening, my colleague. Good evening, our attendees, and welcome for you again. Today, I am going to speak about some important point related to antibiotic, especially inside the ICU. Of course, it is very important and mandatory to know the optimum antibiotic to be selected for a given patient to give a good effect for that patient. And we have a general concept which we are going to speak or to deal with about combination therapy, how, when to combine therapy, beta-lactam allergy. We will discuss also drug level monitoring, aerosol antibiotics, and the de-escalation therapy, which is very important and mandatory, and the antibacterial cycling in each hospital to decrease the resistance of the antibiotic, and also use the pharmacokinetic and pharmacodynamics to predict the optimum dose and optimum time. We will discuss some important points related to antibiotics. And it is very important and mandatory really to know the right antibiotic which you select for your patients according to culture sensitivity. And if empirical, you have to select the optimum one. And also you have to select the right dose and the right route, IV or intramuscular or per oral. And also the right time and the right duration of antibiotic. And don't write antibiotic without ascertain the dose, frequency, and the timing of review, at what time you will review this antibiotic dose. And after that, you have to thinking daily in de-escalation or going down with the antibiotic or changing it or decreasing the number of antibiotics and so on. Today we have many markers for predicting how, at what time we have to start antibiotic in bacterial infection. So not starting empirical. And one of these markers, which I think most of you know it, is procalcitonin. And there are also promethylene and other markers, but the most common which we use in most hospitals now is the procalcitonin level. And every hospital really or every centers target a point at which they start antibiotic, at which they increase or continue the antibiotic, and at what time we have to stop the antibiotic. And they give us also idea about the progress of your treatment. It is going well, it is going in the right pathway, or you starting wrong antibiotic and so on. Mostly we select the value of 0.25 to 0.5 microgram per liters, and according to which we can continue our antibiotic if the patient accepting improvement and accepting decreasing of procalcitonin. Also, the pharmacokinetic and the pharmacodynamic parameters of the antibiotic, very important to be oriented with that. And we have to be oriented. What is the maximum concentrations, which is the peak dose, and what our concentration? What is the minimum MIC, minimum inhibitory concentrations, which affect every organism? And what is the timing spending by antibiotic between the peak and the MIC? And also the duration of the concentration and the pharmacokinetic. You have to know the absorption qualities, the distribution, the elimination, and the effect of your drug which you prescribe to your patient. And as we know, there are antibiotics which depend on concentration effect or efficacy, and the other drugs which depend mostly on time concentration or on both factors, time and concentration effect. For concentration effect, as we know, aminoglycosides depend on concentration effect, and so we try to, or we prefer to give it once daily. Other drugs depend on time as beptazo or beta-lactam, which we prefer now to give it as infusion to cover a long time for its to get its effect appreciated. Concentration-dependent killing activity, which is the relation between the maximum concentration and the minimum inhibitory concentration, or the area under the curve, and MIC, as aminoglycosides, fluoroquinolones, metronidazole, colistin, rifampicin, clindamycin. All these drugs we prefer to start with large dose and over long period of time. If given per day, will be better with initial high concentration because it is concentration dependent effect. Other drugs as beta-lactam depend on timing factor. On examination, the only clear unequivocal reasons to use combination of therapy. Some ask about the combination of therapy. At what time I can use combined antibiotics? You can use combined antibiotic if the bacteria is severely affecting your patient, or your patient is highly septic, like endocarditis, there is prosthetic device, there is joint inflammation with device inside, presence of mycobacteria, typical and atypical mycobacteria, fungi as Cryptococcus. In such a situation, and also in empirical order of antibiotic, we can use combined therapy, combined antibiotics. But during directed therapy and according to culture, we have to use one drug only according to culture sensitivity. And so we can start empirically by combination of antibiotics, and after that we have to escalate to the optimum antibiotic according to the result of the culture, which we withdraw before starting antibiotic management. Also, in some organism infections like severe Pseudomonas infection or high resistance Enterobacteria as Klebsiella pneumonia carbaminase, we can start to combine antibiotic in such exceptionally situations. Combination therapy for gram-negative bacterial infections, as I told, empirical therapy. Directed therapy, don't use combined therapy. Possible exceptions in highly resistant pathogens. Another concept, drug level monitoring. We don't monitor every drug level for every drug or for every antibiotic. Only some drugs we monitoring it because it is nephrotoxic or its efficacy depends on its MIC and the concentration, like vancomycin, gentamicin, voriconazole. We are afraid, of course, from nephrotoxicity and from the lack of efficacy of these drugs if it is below the target level or below the trough level. Other drug level monitoring can be useful, of course. I mean it is not useful, but it is not standardized, and that's not testable. But the most common drugs which we have to ascertain the level of it or its trough level is vancomycin, gentamicin, and voriconazole. About aerosolized antibiotics for treatment, we have, of course, some of us may using it in some resistant disease or some severe RDS patients as influenza pneumonia, or patient with gram-negative pneumonia, or patient with respiratory syncytial virus infections, severe one, or ventilator-associated pneumonia. We can use aerosolized drugs, but we have to take care. This aerosolization may promote bronchospasm, may promote some asthmatic attacks in some sensitive patients, and so we have to be cautious during using aerosolized antibiotics. We can use aerosolized tobramycin or aztreonam, monobactam, in such a situation as Pseudomonas lung disease in cases of cystic fibrosis. After that, I wanted to give some words about the different group of antibiotics. As we know, we have the beta-lactam, we have the beta-lactam drugs, we have the carbapenem, we have fluoroquinolones, we have the macrolides. We have many groups of antibiotics. We speak first about the beta-lactam, just short notes about every group. Beta-lactam, as you know, contains this beta-lactam ring, and all beta-lactam drugs like cephalosporins and like penicillins and aztreonam or monobactam, they have common characters as presence of beta-lactam ring, this one, and also they exhibiting some allergic reactions, especially in between its groups, and also it can cause seizures activity, or the beta-lactam can cause seizures activity. Beta-lactam need frequent dosing for successful therapeutic outcome. As I told, this group of drugs need timing factor for its efficacy, and so now we prefer And according to most of the research work, we prefer to give it through continuous infusion, like Beptazo, like ceftriaxone, ceftazidime, and so on. Beta-lactam classifications, cephalosporins, as I told you, cefalixin, cefaloxime, cefotaxime, ceftriaxone, penicillins, penicillin narrow spectrum, and the broad spectrum one like Beptazo, and the carbapenem like meropenem, imipenem, doripenem, ertapenem, and the monobactam like aztreonam. Anti-staphylococcal penicillins, I just memorize you. If there is a methicillin, which is no longer marketed now. Nefcillin may cause leukopenia during long use. Oxacillin may cause also hepatitis if used for prolonged time. Piperacillin is the commonest penicillin which I think used in the ICU, which is a Beptazo, but take care of sodium load during its use. Because it's about 36 to 90 milliequivalent of sodium in a full daily dose. Also take care of its side effect like platelet dysfunctions. It can cause thrombocytopenia, especially in patients with renal dysfunction. Also, it can give you false positive fungal infection because it gives you, it contains fungal antigen galactomannan and may give you false impression of Aspergillus infection in your patient. Remember, piperacillin cover Pseudomonas, which is very common and very potent against Pseudomonas. The doses, as I told in the first slide, you have to consider and give attention to the right dose. Beptazo, one of the drugs which we have to use frequent doses or continuous infusion because it depends on time factor for its efficacy, and so we use it 4.5 gram per 6 hours, better than every 8 hours, and better to give it through infusion. And really, the infusion of beta-lactam drugs decrease the toxicity of the drug and decrease the nephrotoxicity. If we start to give idea about the cephalosporin spectrum, we have now about 7 generations of cephalosporin. First generation is as cefazolin, and it can attack the methicillin staph sensitive, Staph Aureus, E. coli, Klebsiella. No activity versus the enterococci. Most of the cephalosporin mostly not affect enterococci. Second generation cefoxitin and the cefotitan, and it is it can cover bacteroids as Fragilis resistance increasing, and as we increase in the generation, the covering of anaerobic antibiotic by cephalosporin is decreasing. And we can see the first generation and the second generation may affect the anaerobic, like Fragilis bacteroids. But after we go into the third and fourth, it is not effective against anaerobic. Third generation ceftriaxone, and they start the gram-negative activity, as you know, and the spectrum would be extended more better and more wide. And the take care ceftriaxone may cause some biliary stones and the biliary sludge, and so it is not good in cases of biliary infection. Fourth generation as ceftazidime, cefibime, and they start here the efficacy of cephalosporins against anti-pseudomonal infection. Cefibime and the ceftazidime, effective against gram-negative and also anti-pseudomonas at the same time. Fifth generation ceftaroline, and this is the only cephalosporin drug which can be used for MRSA, for methicillin-resistant Staph Aureus. This is the only cephalosporin ceftaroline for covering MRSA or methicillin-resistant Staph. Sixth generation and the fifth and the seventh generation really for the multi-resistant organism as extended spectrum beta-lactam and gram-negative bacilli like ceftolazone, tazobactam combination, very effective, and we reserve it for very potent or very highly infected patients. Also, the seventh generation with ceftazidime with avibactam, and it can cover extended spectrum BL, and also gram-negative bacilli and Klebsiella carbapenems. No activity versus anaerobic organism. Only the second and the fifth generation of cephalosporins active against viruses. And the take care of allergy decreases with going up in cephalosporin generation. As we go up from the first to the seventh generations, the allergy complication decreases from cephalosporin. Cephalosporin, if we speak short note about cephalosporin and the ceftazidime. Cephalosporin indicated in bacteremia, pneumonia, skin and soft tissue infection, in febrile neutropenic patient, urinary tract infection, gynecological infection, and abdominal infection. Use high dose to get an efficacy, really. It need at least 2 grams every 8-hour IV in adult patients. It also can cover the gram-positive and the gram-negative. Gram-positive enhanced activity, including MRSA and pneumococcus, compared to ceftazidime. About enhanced activity for MRSA, it is query, really. And some research against it and using with vancomycin as an enhancing action against MRSA infection. Cephalosporin also cover gram-negative routes as enhanced activity against extended spectrum beta-lactamase producing routes, better cell wall penetration, less affinity for some beta-lactamases, and binds to multiple penicillin binding protein. And really, it is a very good drug, cephalosporin, and we depend on it sometimes the others. Cephalosporin drug level are insufficient in patients with severe infection. Always in severe infection, the drug doses need to be increased to some extent, especially in cephalosporin and ceftazidime and vancomycin. We increase cephalosporin to 2 grams, as I told you, every 8 hours for highly septic patients. Don't forget, there are now 9 current drugs active against MRSA, methicillin-resistant Staph aureus, which are vancomycin, and still the best drug, really, vancomycin. Tilivancin, dalbavancin, oritavancin, daptomycin, ceftaroline, cephalosporin, linezolid, oxazolidone, and tidzolid, oxalizodone also, and clindamycin. 9 drugs now you have to cover MRSA infection. Suppose your patient is suffering from sepsis with Staph aureus, and you don't know which is infection with Staph aureus, methicillin sensitive or methicillin resistant. Which drug you use, Vanco or Dapto or oxacillin only? If you don't know the organism, but you just know it is a Staph infection or Staph sepsis, you have to give vancomycin or daptomycin. If you know it's only Staph, sensitive Staph, you have to give oxacillin, not oxacillin with vancomycin. But if you don't know, you have to give the combined vanco and oxacillin. In oxacillin sensitive, you can give oxacillin only or cefazolin, first generation, or cephalosporin covering Staph. In oxacillin resistance, you have to give vancomycin or daptomycin. Suppose your MIC in your patient becoming greater than 2 micrograms per ml at time, you have to end problem now. You have to think in another drug. Don't increase the dose of vancomycin, but you have to think in another drug against the MRSA, because this meaning is the patient exhibiting, or the organism, the MRSA, start to exhibit some resistance to your vancomycin. How long does Staph bacteremia persist on adequate therapy? You can start vancomycin and you pass in the correct pathway and you manage correctly, but still you can reveal some staphylococci in your culture. And so the organism can stay in the culture for up to more than 7 days, sometimes 3-4 days, sometimes more than 7 days. You can still find the Staph in your culture, in the blood culture. Especially with MRSA, more than methicillin sensitive, also in presence of endovascular infections, in foci, and in diabetic or in immune compromised patients. And so we have to prolong your treatment for Staph sepsis. Staph aureus sepsis is very important. We have to take serial blood culture to determine the persistence, especially in cases of endocarditis, which you can't reveal or you can't discover except through TE, esophageal echo. You can't predict these small vegetations less than 5 millimeters through transthoracic echo. You have to make transesophageal echo, and you have to make it after 5 or 6 days from infection. Before that, vegetations, I think, will not be formed. Also in septic phlebitis and sequestered mucus, or in the presence of intravascular device, we have to remove any device if you can, in cases of septicemia with Staph aureus. Also, treatment of bacteremic Staph aureus in a combination therapy with rifampicin or gentamicin, as we see. Rifampicin and gentamicin actually, we can use it with vancomycin just for a few days, 1 to 3 days, just to enhance the efficacy of vancomycin or the treatment, but don't exceed 3 days in such situations. Combination only if prosthetic device is present, retained or replaced, you have to combine to just give more efficacy to your vancomycin. Optional for 3 to 5 days to reduce the duration of bacteremia. Duration of treatment for Staph, sepsis or bacteremia. If the patient uncomplicated, we can treat for only 2 weeks. But suppose your patient complicated, you have to treat for 4 to 6 weeks. How I can or how I differentiate between complicated and suppose your patient immune compromised. Suppose your patient there is still intravascular device. Suppose your patient is still febrile, neutropenic. These patients need continuation. Suppose your patient excepting by echo, still there is vegetations or endocarditis, or your patient excepting some thrombophlebitis, you have to continue for 4 to 6. And so we have, this is very important and mandatory to differentiate between the complicated and uncomplicated case of Staph infection. Staph aureus bacteremia, we have to differentiate between complicated and uncomplicated. For the board, you can select the longer durations, more safe, and always, as I said, remove the catheter, remove the device, and you have to be oriented with the criteria to just only use treatment for 14 days. In such situations, if the old catheters are removed or replaced not through guide wire, no replacement of catheter now, intravascular catheter with guide wire, abandoned now, prohibited. You have to select another site. No fever in 72 hours. Not immune suppressed, your patient not neutropenic, not immune compromised, and so on. Blood culture is negative by 72 hours. No intravascular prosthetic material, pacer, valve, and so on. The transesophageal echo negative for vegetations on day 5-7, not less than this. Don't make TEE after 3 days and you told me it is negative. Okay, patient, okay, you have to wait for 5-7 days. Ultrasound negative for thrombophlebitis or physical examination negative for metastatic infection. All these criteria preclude you or allow you to use only 2 weeks of treatment, not more. But if your patient complicated, you have to continue for more time, for 4 to 6 weeks. Look for complications of Staph aureus always. We can see in Staph aureus infections or Staph aureus bacteremia, we can see endocarditis, which is discovered through echo. Back pain, maybe the patient complaining of osteomyelitis and epidural abscess and they started to feel weakness and numbness in the lower limb and so on. Joint pain, look for septic arthritis. All these are complications of Staph bacteremia. Leg weakness and incontinence, look for epidural abscess. The cardiac device or any prosthesis removal is always preferred. The other drug is from the 5th generation of cephalosporin, ceftaroline. Ceftaroline, which I told you, effective against MRSA also. Cephalosporin with MRSA activity, active against MSSA sensitive and MRSA, methicillin resistant staph, also against pneumococci, active against Enterococcus fecalis, not faecial, active against Enterococcus Cephalosporin not in general not active against Enterococcus, except ceftaroline may be active against, but only fecalis, Enterococcus fecalis. If VRE or Fecium, we have to use linezolid, not using ceftaroline or vancomycin. Actively, again, gram-negative rods similar to ceftriaxone, the same spectrum. Its dose 600 milligram every 12 hours with renal adjustment. Most of the drug take care. If your patient complaining of renal problems, you have to adjust your dose. I see with cephalosporins for MRSA, breathable, but no extensive data. I can use for bacteremia ceftaroline really query eternal, like linezolid, when using ortigocycline. In cases of bacteremia, maybe query these drugs if it is so efficient to cover bacteremia. Vancomycin, it is active or have broad spectrum activity versus aerobic gram-positive. Cover gram-positive, not covering anaerobic, not covering gram-negative resistance with vancomycin resistant enterococci or vancomycin resistant staph. It is very rare, very rare, about 30 cases all over the world. Bacterial killing related to time of concentration, more than MIC. Related to time of concentration, more than MIC. And so some prefer giving it through infusion or giving large dose at start as about 30 milligram per kg. To maximize the safety and the efficacy of intravenous vancomycin therapy for MRSA sepsis would be to maintain trough level 15 to 20 microgram per ml. This is the optimum therapeutic level of vancomycin in cases of treatment. 15 to 20 microgram per ml. No peak measurement, no peak measurements in vancomycin, only trough. And you have to measure the trough after 4 days. And during your writing the antibiotic you have to ascertain at what time you want to measure the trough level, at what time you want to stop your drug, for how many days. Don't forget the drug. Don't write مثلا vancomycin 1 gram BID and leave it forever. We see many complications from such orders really, which is not competent. Vancomycin poor penetration to the lung and CNS, in contrast to linezolid. Linezolid more penetrating to lung and CNS. Resistance is still rare. About 3 cases I told you, or 30 cases over the world. Don't forget the trough sample after 4 days for vancomycin. Vancomycin doses load with 25 to 30 milligram per kg. We prefer this high dose. 2 gram for 70 kilogram, and then after that 15 to 20 milligram per kg every 8 to 12 hours. From actual body weight, of course. Toxicity take care of Redman syndrome if you inject your drug very rapid, and so better to give it slowly and through infusion. Don't forget the renal complications and nephrotoxic, and also the otic or auditory complications. And really the auditory complications you can't predict in the ICU, especially with vancomycin, with other nephrotoxic drug like aminoglycosides, because it needs audiometry recording, and your patient can't tolerate audiometry, or we can't send them, most patients, to audio lab to check the effect of nephrotoxic drugs on the auditory nerve and the vestibular nerve. And you have to know it affects early the smallest fiber of the H nerve. And so you can't predict its side effect as auditory complications except by audiogram. No one can decide if the patient affected or not except by audiogram. The patient hearing well and no problem, but he may be affected to some voice because the smallest fiber is affected early. And as you know, also it affects the vestibular nerve. Your patient starts after that to complaining of dizziness, complaining of tinnitus, drowsy, instability, and so on. Don't forget the leukopenia, which can be caused by vancomycin. Don't forget the ITP. Most of immune thrombocytic purpura or immune thrombocytopenia occur due to drugs. One of the most common drugs is vancomycin, and linezolid can cause some sort of thrombocytopenia. Linezolid causing through bone marrow suppression. Scan may cause immunoglobulin A bullous dermatitis. As I said, the infusion with vancomycin, some prefer infusion with vancomycin, especially with high dose 30 milligram per kg daily, and others still attached to the traditional one, which giving the drug daily, BID daily every 12 hours. Slower onset of nephrotoxicity with continuous infusion of vancomycin, it is settled by most of the research. Avoid empiric use, especially more than 3 days. Don't use vancomycin more than 3 days, except if you use that empirically. If you start your drug vancomycin in any critical septic patient with vancomycin, empirically, you have to take culture before and you have to follow the culture. Don't delay or don't prolong the duration more than 3 days, except with cultures in front of you, saying that your patient is infected with MRSA, but don't give empirically more than 3 days. Is it needed after 3 days? You have to ask yourself if the patient improving or no, and so on. Do you need to draw vancomycin level? Of course, it is very important to reduce the toxicity, renal and otic, and assure efficacy of the drug. As I told you, the goal is our trough level 15 to 20 microgram per ml measures after the first dose. We need, the other asked, we can need peak level, no need for peak level and vancomycin, only trough level, which is the minimum concentration, which is the sample taken before the starting the next dose, at the end of the first dose. Vancomycin resistant staph, as I said, it is very rare now. It is very rare, about 30 cases. Linezolid is another drug. It is a bacteriostatic, not bactericidal, but it may be bactericidal in some cases, or if we use it in large dose. Dose 600 milligram IV or per oral BID. No adjustment for liver or renal diseases, but really there are some liver problems and renal problems also. We have to take care. There may be minimum, but we have to take care. Adverse effects of it: diarrhea, bone marrow suppression, very important. By 10th day or 12th day, you will face your patient anemic or just low RBCs and platelets very low and so on. And so leukopenia and thrombocytopenia after 10 to 12 days, very common. Take care also of serotonin reaction, serotonin syndrome, and lactic acidosis. Peripheral neuropathy, the patient started to complaining of some numbness in the lips and lactic acidosis and optic neuritis. All these complications could be faced with linezolid. But it is good drug really in penetration in its efficacy for treating pneumonia, for treating lung infection and CNS, because it penetrates and its level is high in the bronchoalveolar lavage or CSF more than serum. And so it has a good ability of penetrating CNS and lung tissue more better than vancomycin. And we can use it in severe pneumonia. We failed with other drugs. Linezolid in a concern about use in bacteremia. The questions, we can use it in bacteremia query really, if it is more efficient in bacteremia or no, you have to use with it another. Possibly preferable to vancomycins in cases of oxacillin resistance, Staph aureus, pneumonia, skin and soft tissue. Inhibit toxin release as does clindamycin. As clindamycin, it inhibits the toxin release. Tidozolid is like Cefextro is like linezolid, but it is used once daily, and the serotonin side effect less, incidence is less with this one. It could be used for vancomycin resistant enteropyla VRE. Lower MIC than linezolid, and so its efficacy and toxicity is less. Nausea may cause nausea, vomiting, diarrhea, serotonin syndrome when used with other, especially when used linezolid or tidozolid with other drugs like SSRIs, serotonin inhibitors, uptake inhibitors, or monoamine oxidase inhibitors, especially in depressed patient or psychic patient. You have to take care, may cause serotonin syndrome, and you start to face your patient febrile, rigid, and exhibiting abnormal movement, and so on. Advantage over linezolid, tidozolid, much less bone marrow suppression, maybe leukopenia and thrombocytopenia as so much. Once daily, you can use it once daily, twice daily. As Daptomycin is a good drug. It is a bactericidal drug, killing the bacteria, active against almost gram-positive. Okay? Dose must be adjusted when creatinine clearance less than 30. Available only IV, few drug interactions, but take care, it can cause some sort of eosinophilic pneumonia and infiltration of eosinophils to the lung. It is also inactivated by surfactant in the lung, and so not affected in some lung infections. Could be used for skin, soft tissue, bacteremia, right side endocarditis. Meningitis, it is good for CSF penetration, but limited clinical data for its use for CNS infection. All of us use cephalosporin, ceftriaxone, and other drugs use ampicillin in old age and immune suppressed division. Daptomycin toxicity, muscle pain, take care, because muscle pain, it elevates the CPK, creatinine kinase, rhabdomyolysis, eosinophilic pneumonia, chronic pneumonia, prolonged use could cause neutropenia, problems, poor penetration into lung, and the surfactant binding and inactivation by surfactant, and so not effective in lung infection. Approved drugs, recent drugs, which I told you, uretivancin, tilavancin, dalbavancin, combination drugs for gram-negative rods, which 6 and 7 generation of cephalosporins like ceftolazone, tazobactam, and ceftazidime avium. These are new drugs and very effective in resistance. If we shift now to speak about macrolides, which characterized by common ring, which is the lactone ring, as erythromycin, telierythromycin, and azithromycin, and clarithromycin. These drugs are very effective, especially against atypical organisms like chlamydia and legionella and so on, and atypical pneumonia. Mechanism of action, bacteriostatic usually, and inhibits the bacterial RNA-dependent protein synthesis, affecting 30 S ribosomal and 50 ribosomal subunits, impairing protein synthesis. A spectrum of activity of macrolides, it can cover gram-positive and gram-negative ROPs. Clarithromycin more than erythro and azithro for gram-positive. Gram-negative affected more by azithromycin more than clarithromycin. Spectrum of activity, no activity against enterobacteria, but it can cover anaerobes, upper airway anaerobes, and it can cover atypical bacteria. The carbapenem group or carbapenem drugs like imipenem, meropenem, ertapenem, and doripenem, we have to know all these drugs cover oxacillin-sensitive staph. Very effective in covering staph virus, not affecting MRSA. Carbapenem, not all of them not affecting MRSA, but all of them very effective against pneumococcus. They can also affect Enterococcus faecalis only, not faecium, not affecting Enterococcus faecium. Also affect very good drugs for gram-negative drug organism. All of them are effective against anaerobe. All of them are effective against Pseudomonas except ertapenem. Ertapenem really is a very good drug because it is used once daily, but it is not effective against Pseudomonas. But the other drugs are effective against Pseudomonas, against anaerobe infection, against gram-negative organism, against Enterococcus faecalis only, against the Staph aureus, not affecting MRSA. Which carbapenem should you use? Of course, most of us use imipenem because it is very cheap and most common drug we use, standard one. Meropenem may be exhibiting fewer seizures activity. Doripenem is good for best Pseudomonas covering. Ertapenem is no Pseudomonas covering, but few seizures activity and could be used once daily. The other group of drugs which is very common, the fluoroquinolone drugs, which as ciprofloxacin and levofloxacin and moxifloxacin. Cipro is covering urinary tract infection and more specific to gram-negative. Yeah, can cover gram-negative drugs. Gram-positive maybe, but levo and moxi also cover gram-positive. All of them not covering enterococci, like cephalosporins, no covering enterococci. Also, anaerobes not covering anaerobes, except moxifloxacin may cover anaerobic, but weak covering effect really. For gram-negative, Cipro is the best, followed by levofloxacin and moxi. Moxi is the best for respiratory, and followed by levofloxacin. Gram-negative for anaerobes, as I told you, not covering anaerobes. For Pseudomonas, moxifloxacin not covering Pseudomonas, but covered by levo and ciprofloxacin. Quinolones in general is a poor choice for Staph aureus in general. No activity against MRSA or Enterococcus. Only moxi has activity, some activity against anaerobes. Flagging activity against gram-negative roles. About in pneumonia, in atypical pneumonia, moxifloxacin and levofloxacin, and try to use the largest dose, which is 750 milligram daily. It is a time factor efficacy, quinolones. Gram-negative infections, it is not so good with quinolones, really, but Cipro or levo is more better as gram-negative. Moxifloxacin not covering gram-negative. Don't use quinolones in case of meningitis. Don't use quinolones in case of meningitis or patients suffering from some sort of CNS infection. As we know, quinolones may cause some side effect, seizures activity, maybe altered mental status, and many patients taking quinolones suffering to you, they can't sleep well and they dream bad dreams, they sleep with bad dreams. Also take care of collagen affection, especially Achilles tendon rupture, and really it affects all tendons of the body. Take care of using it too much, it affects the collagen tissue of the patient. Also may cause rash, prolonged QT, very important. And macrolides also, don't forget macrolides, causing prolongation of QT interval more than 450. Hypoglycemia may be caused by gaty fluoxacin. The other group, which is an important group, the aminoglycosides, which depend on concentration dependent, as I told in the start of the lecture, and it has renal and ototoxic activity. Renal activity can cause acute tubular necrosis. Gentamicin and tobramycin more nephrotoxic than amikacin. Volume and electrolyte correction. Try to hydrate your patient. Try to overhydrate. Otic complications, as I said, the auditory and the vestibular complication, and it is irreversible, this complication, auditory and vestibular, and that affects the small fibers and must be detected by audiogram. Better to use it once daily dosing, perhaps less nephrotoxic and may be more effective. Well, I think most of us are afraid of using too much or for too long time, besides because it has many side effects. Traditional doses every 8 to 12 hours, we can use gentamicin, tobramycin every 8 to 12 hours. We can use it every 24 hours. The dose for every 24 hours, which is the best, gentamicin or tobramycin, 5 to 7 milligram per kg per 24 hours. For amikacin, 15 milligram per kg every 24 hours. And I said it is a concentration dependent, and it is less nephrotoxic when using it as once daily. Aminoglycoside levels peak for traditional one every 6 to 8 hours, about 3 to 4 microgram per ml. In severe cases, we can go up to 12. A trough for 24 hours maybe trough may be 1 to 2 microgram per ml. How to use aminoglycosides, as I said, with combination with other drugs to potentiate in cases of endocarditis and severe infection for 1 to 3 days or 4 days. After that, the adverse effects of aminoglycosides, as we know, ototoxicity and neuromuscular paralysis, and I think most of the anesthesiologists are not using it except with depolarizing. Don't use it with non-depolarizing, especially with patients exhibiting a muscle disease, especially myasthenia gravis or Barré or any muscle disease. Better to not using aminoglycosides in such patients. Extended spectrum beta lactamases, as I told, the general hydrolyzed beta lactam drugs as penicillin, cephalosporin, monobactam. Extended spectrum beta lactamase we can use in such situations carbapenem. Don't use piperacillin even if the culture show you a culture sensitive positive for piperacillin. Don't use it. And extended spectrum beta lactamases we have to use carbapenem, or we can use quinolones and aminoglycosides if susceptible. Of course, Acintobacter and the other drugs as Newdelia and the drugs which is very highly resistant, we can use polymyxin or colistin or polymyxin or phosphomycin especially for urinary tract infection, and tigacycline, aminoglycosides, stellionam, and ceftazidime avibactam, which is a combined or 7th and 6th generation of cephalosporin. In urinary tract infections, we can use in resistant cases phosphomycin, or we can use combination therapy recommended by some experts. Colistin, as you know, colistin or polymyxin, we can use it in adult 9 million units. You can give it once, starting those, and after that 3 million every 8 hours, especially in cases of Acintobacter and Pseudomonas infection. These are the drugs which polymyxins, as you know, poor penetration to lungs and CSF. And really, we faced with some patients who suffering from CNS Acintobacter, and we started to treat them with polymyxin locally. Through the AV shunt, if it is present, or through the drain of the CNS, we initiate with so many patients and exhibiting improvement, but they take long time really to be treated with polymyxin local and IV also. Local and IV. And in combination with rifampicin, exhibiting improvement within 1 month, 2 months. Take care of polymyxin toxicity as nephrotoxicity or neurotoxicity or ataxia, reversible, oral paresthesia, and so on. Tetracycline as doxycycline and aminocycline and tetracycline and tigacycline, and I think most of you know tigacycline, which is a common drug now used from the group of tetracycline. It is a bacteriostatic, or this group, bacteriostatic effect. Spectrum of activity all have similar activities: gram-positive aerobic cocci and rods, covering staph and strep, gram-negative aerobic bacteria, and the atypical doxycycline cover mycoplasma, chlamydia, rickettsia, protozoa. Is a common drug used in such situations. Adverse effect, you know, the permanent discolorations of toes and bone of the baby, and so not using in pregnancy. Tigacycline, I think most of you are using it. Gram-positive, covering gram-positive and gram-negative, but take care it sometimes, and it is specific for VRE and enterococci. VRE, vancomycin resistance enterococci, and for enterococci, it can cover E. coli, Klebsiella, Stenotrophomonas, and also cover bacteroids, but it may cause some pancreatitis or some hepatitis side effect, and it has also some catabolic effect. Don't forget the anaerobic spectrum of some drugs as metronidazole and clindamycin, tetracycline, clavulanate, piperacillin, and imipenem and meropenem or carbapenem all cover the anaerobic bacteria. Metronidazole, as you know, covers the anaerobic, which is abdominal, clindamycin, the other parts of the body, upper and lower half of the body. And I think enough today to speak about it. Just the important points of antibiotics.
Thank you so much, Professor Ansari. Thank you so much for the interesting lecture. It's a big topic, we know, and this is very hard to cover in a limited time. But thank you so much for educating us on this subject. Next, our speaker is Dr. Walid. Dr. Walid Shibl, he is a consultant intensivist in Qatif Central Hospital in Saudi Arabia. He graduated from Cairo. He has a master's in medicine from Cairo, MRCP from UK, and he has a specialty certificate in acute medicine from the UK, and he is board certified in echocardiography from the US. His lecture is going to be about airway pressure release ventilation in severe COVID-19 ARDS. تفضل دكتور وليد. Go ahead, please.
صوت دكتور وليد.
Okay. It's okay now? It's okay?
Yes.
Okay.
Thank
Yes,
you.
it's okay.
Okay. We'll talk about rescue ABRV, airway pressure release ventilation in severe COVID-19 ARDS. What does it mean? If you face a COVID-19 patient with white lung and impossible and to ventilate by conventional ventilation, pressure or volume control, this is very bad scenario, and you don't have the resources for ECMO. Think about this rescue ABRV. I tried a lot. It works. It helps a lot, really. Let us see what is meant by rescue ABRV. It's very simple mode, but very efficient in severe ARDS patient, especially COVID patient. I have no disclosure. This is a 43-year-old male patient who was admitted to our ICU from ER with very bad COVID-19 pneumonia. He has severe respiratory distress. O2 saturation dropped to 48%. He lost consciousness and intubated, ventilated in ER. This is the X-ray of the patient. Almost left lung gun, right lung upper loops, lower loops, and even there is infiltrate in the middle loops. ABG in ER very bad with pressure assist control, 28 centimeter water above PEEP 10, with respiratory rate 22, IE ratio 1 to 2, severe respiratory and metabolic acidosis 6.9, BCO2 79, VO2 58, bicarb 11. You are talking about BF ratio less than 60, which is refractory hypoxemia and severe bad acidosis. Respiratory rate increased to 30 per minute. Patient giving shots of bicarb, pressor started. I saw the patient next morning. He was fully sedated, paralyzed, heart rate 100 per minute, blood pressure 90/60. All inflammatory markers are shooting up. In chemistry, there was increase in BTT, hyponatremia, hypokalemia, liver enzymes increase, hypoalbuminemia. We used to do full critical care ultrasound for this COVID patient. The inferior vena cava was collapsing with this patient with triggered breast. Inferior vena cava was collapsing. Parasternal short axis view, global hypokinesia, are talking about 20% ejection fraction. Fourth chamber view, global hypokinesia. The diameter, the diastolic diameter was normal. That's going with acute heart failure in COVID patient. You think about septic myopathy or stress myopathy. We did lung ultrasound. Really, there was a lot of consolidation. And if you see this consolidation in COVID patient, this hepatization COVID patient, really, it's grave sign. It is very bad sign because this consolidation is not used to see in moderate case of the COVID. You used to see this confluent B line, but if you see this consolidation in the right blab and the left blab with effusion, which is rare in COVID patient, lung water score was 22/30, going with white lung. We did DVT study. The patient has good collapsing of the common femoral, no DVT. We used to see the vital organ perfusion by looking to the most important vital organ, which is the kidney. We look for the perfusion of the kidney. As you see here, all the vascular bundle restricted to the hilum, supposed to go near the capsule here. That means this patient has renal hypoperfusion, which is going with the scenario of the patient. Severe ARDS, acute heart failure, low perfusion, difficult to ventilate with conventional breathing, with conventional ventilation. Critical care ultrasound report, severe COVID pneumonia, white lung on X-ray chest, very high lung water score, 22/30, difficult to ventilate by conventional pressure control mode, severe left side heart failure, diastolic dysfunction grade 1 with normal left atrial pressure, hemodynamic compromise of the kidney, no DVT, but the patient is fluid responsiveness. And this COVID patient early in admission because of tachypnea with huge insensible loss, and some patient has diarrhea and the fever. Usually this patient is fluid responsiveness on admission to the hospital. We started our protocol for COVID-19 pneumonia patient, interferon beta 1b, ribavirin, lopinavir, ritonavir, enoxaparin, steroid, azithromycin, ceftriaxone. We add dobutamine 2.5 mg per kg per minute as inotropes because of heart failure, acute heart failure, add noradrenaline 5 mg per minute, and we give IV fluid challenge, boluses of IV fluids. After boluses of IV fluids with inopressors, the blood pressure really improved, mean arterial pressure 75 millimeter mercury, but still we are struggling with oxygenation and ventilation of the patient, high sitting with saturation always below 85, acidotic, on high 100% FiO2, pressure control 28, above beep, and beep 10, you are talking about peak pressure 38, we reach dangerous level, and we reach maximum respiratory rate 35. It is very bad scenario and very bad time. During this time, please think about rescue ABRV, because usually you don't have in this COVID era, you don't have available ECMO nearby. Let us talk about the airway and pressure release ventilation, ABRV. To talk after that about rescue ABRV. ABRV is very old mode since 1987. Professor Nader Hibashi, which is associate professor in Maryland University, one of the pioneers in the ABRV, he talked with other pioneers, Benny, Josh, about the ABRV in this review in intensive care medicine. They mentioned in brief, airway pressure release ventilation is all mood. It's defined as continuous positive airway pressure. It's continuous CPAP with brief release, while allowing the patient to spontaneously breathe throughout the respiratory cycle. The current understanding of the good mode to prevent ventilator-induced lung injury is to open the lung and keep it open. ABRV should be ideal for this strategy with prolonged CPAP duration, recruiting the lung, and the minimal release duration preventing lung collapse. Let us explain every word of this abstract. All of you know this famous pressure volume curve in patients with ARDS. And I believe all of you know about lower inflection point, and you are trying to give your PEEP 2 centimeter water above the lower inflection point to recruit the patient. Because in this lung volume, in our patient, in this lung volume with bad atelectasis, collapse, edema, it is very hard to give volume to the patient. You need too much pressure for very minimal volume. But in this steep part of the curve, in this steep part, which usually in the functional residual capacity of the patient, this will call recruitment. In conventional mechanical ventilation, you are recruited in this area, 2 centimeter water above the lower inflection point. But as we will explain now, ABRV is highly recruitable mode. It's very efficient in recruitment. So your patient volume and functional residual capacity will be in this area, around functional residual capacity. So your patient will be in this area of the curve, not this area, will be in this area in the curve. And after proper recruitment of the patient with ABRV, will keep the patient breathe spontaneously in open circuit. So he can generate very minimal effort, can generate very minimal pressure to gain a huge volume, a huge tidal volume. So it is cost benefit spontaneous ventilation. Let us see what's going on with ABRV. What you are going to set in ABRV is 4 parameters. You are going to set B high, which is the peak pressure. This is the B high, peak pressure. How can you select the B high? Very easy. Go to your patient on volume control and look for the plateau and take this plateau as a B high. Okay, if the patient has severe ARDS, like our patient, start by 30 centimeter water, which is the maximum. Okay, this is very easy. This is a B high, okay? For how long you will keep this B high? You will set the T high, the time high. In conventional ABRV, it's 5 seconds. So 30 centimeter water over 5 seconds. What will happen after 5 seconds? The ventilator will recycle, time recycle after 5 seconds. The pressure will drop to 0, which is the below. You will say to me, Walid, what are you going to do? You will recruit the patient to 30 centimeter water and de-recruit to 0. This is the best way to induce atelectic trauma and lung injury. Wait, this is the value of the T low. We'll adjust the T low in conventional ABRV 0.5 seconds. What does it mean? After 5 seconds, the pressure will drop from 30 to 0. So there will be exhalation, there will be release. The lung volume will be exhaled, but not all lung volume, because I will not give time to allow for complete exhalation of lung volume. I will give time low to keep only partial exhalation, and I will keep volume inside the alveoli, and I will do O2 beam. Okay? Because if you increase the T low, this is the flow, expiratory flow. The expiratory flow will go to the baseline. This is not the case in ABRV, and I will tell you how to do it very simply. In ABRV, we'll keep only 0.5 seconds, so we'll give this truncated expiratory flow and this O2 beam. And we'll keep this end expiratory flow, we'll keep it 75% of the peak expiratory flow. Okay? In this way, I will do very good recruitment, and I will keep the recruitment by O2 beam and the residual function, residual capacity. I will keep volume inside, and at the same time, I will keep the patient to spontaneously breathe whenever he needs in the B high or B low. As you see here, the patient is taking a spontaneous breath, very calm spontaneous breath, because this spontaneous breath happened on the best pressure volume curve. So he need only to generate a little pressure to gain a lot of volume, and I can give automatic tube compensation to help the patient more. If I don't have the automatic tube compensation, I can give 5 centimeter pressure support. Okay. Very simple mode, 4 parameter, almost stable for almost all the patient, and you can adjust after that. I will tell you how to do it. But the philosophy and the idea behind ABRV is very important recruitment. Look for this. Look for this area under pressure time curve. It's great. You see, huge area under the curve. This is the pressure for 5 seconds. The huge area under the curve, which give huge mid airway pressure and very efficient recruitment. And at the same time, I keep the patient spontaneously breathe with all the benefit of spontaneous breathing. Like we'll see now the huge benefit of spontaneous breathing in this way. You see, this is the effect of the time with pressure for recruitment. Look for this big lung in the experiment. Now we do a pressure for 1 second here. The Dr. Nader Hubashi did this experiment with on animals on the pig. You see, after 1 second, this is the only area recruited. All this area are not recruited. But increasing the time of peak pressure, look what will happen. Amazing. This is the effect of the time with pressure on the recruitment. And look for the alveoli. A lot of alveoli are recruited. And the very huge surface area will happen for exchange. And we'll see how this effect very efficient in the ventilation side. So time-related recruitment is the ABRV. We are keeping 5 seconds with big pressure for proper recruitment. And once you recruit, you will keep the patient to breathe spontaneously for the benefit of spontaneous breath. Look for, this is the patient with ABRV with spontaneous breath. He is pulling the air inside the chest with movement of the diaphragm, but this is a conventional air ventilation with movement of the chest wall, and there is a lot of atelectasis here and here. This is spontaneous breath will give very efficient distribution of the ventilation, especially in the basal area, and will be great ventilation perfusion mismatch. And as you see here in this review, in the Department of Anesthesia and Intensive Care, University Hospital Zagreb, they talk a lot about spontaneous breathing benefit. You look for proper pulmonary gas exchange, systemic blood flow, oxygen supply to the tissue, because with spontaneous breath, you generate negative pressure, so you will suck the blood, and at the same time, you will distribute the ventilation by pushing the diaphragm down, you will distribute the ventilation to this area, which there is a lot of consolidation in ARDS. So you will match ventilation perfusion very efficiently in this situation. Okay. This is the overview about airway pressure release ventilation conventional. Now, what is the difference between conventional and rescue ABRV in COVID-19 severe ARDS? Really, there is a problem if you use the conventional ABRV in the COVID patient, because our patient with white lung and severe acidosis and CO2 retention, there's a problem in the setting of the ABRV. As you see here, to wash the CO2 in ABRV, you have two ways to wash the CO2. The first one is the bulk wash by minute ventilation, okay? The second one by diffusive wash, which is by proper recruitment of the alveoli. You will have a lot of alveoli recruited, so the surface area for diffusion will be great, so the exchange of gases will be great, so you will see a lot of CO2 in the airway at any time, so you will exhale a lot of CO2. This is called diffusive wash. This diffusive wash need time. You are talking about at least 6 hours to reach the proper recruitment and start to reach stabilization of alveoli. Time. During this 6 hours, our patient really will not tolerate CO2 rise in this time, because if you adjust the time high 5 seconds and time low 0.5 seconds, that means you will give breath almost every 5 seconds. That means you will have only 12 breaths per minute. 12 breaths per minute with tidal volume 400, 450, you are talking about almost 5 liters. 5 liters in our patient, he will arrest because of respiratory acidosis. This is the value of rescue ABRV. The only difference between the conventional ABRV and the rescue ABRV is the time high. Will in rescue ABRV at start of ventilation of our patient will make the time high 2 seconds, and we can make it 1.8 seconds. So you can expect at least 25 to 30 breaths per minute, and you can wash by bulk wash by increasing minute ventilation until recruitment happen after 6 hours, and after that you can increase time high. This is the philosophy of rescue ABRV. And this rescue ABRV, it's not my invention. It is the invention of this great group of Nader Hubashi in Maryland University. They did this review of ABRV network in 2020 and talk about this rescue mode. I tried in at least 15 patients till now. It works very efficiently, really. Okay. What is the precaution you need to take during ABRV setting? First, we talk about P high. P high, I will repeat again, make it simply 30 centimeter water or plateau pressure. Okay. But what is the drawback of P high? If the P high is too high, it will lead to overdistension. How can I assess this overdistension? You have two ways. If you have ultrasound machine, you can look for the diaphragmatic movement. If you have this great diaphragmatic movement, that means no flattening of the diaphragm. But if you don't have the ultrasound machine, just very easy, do X-ray chest on your patient and be sure the maximum curvature of the diaphragm should be in the mid-clavicular line on chest radiography, not to be in the periphery. Okay, that means the diaphragm is not flat, it's curved, because we need the patient in this part of the pressure volume curve, not in this part over distension. This is number one, B high. T high, this is the only change as in rescue strategy. As I said to you, they decrease the T high to 2 seconds and you can go lower than 2 seconds to lead to bulk ventilation, to increase minute ventilation until recruitment take place. Okay. Right. What about below? Below always zero. Below always zero. Very easy in conventional and in rescue ABRV. What about T-low? T-low is a cornerstone of the ABRV. As I said to you, you will go from 30 centimeter water, you will drop to 0. This is the expiratory flow. As you see here, this is a big expiratory flow, and this is the T low. You will keep this T low to make this a portion of this end expiratory flow and this auto beep. Okay? I need this big end expiratory flow. I need this end expiratory flow 75% of peak expiratory flow. يعني if the peak expiratory flow is 70 centimeter per second, this will be this low. If it's 100, this will be 75. Okay, it's very easy. How to do it? I will look the screen, and there is a scroll bar. I will take this scroll bar and I will measure this peak expiratory flow. Okay. And I will go with the scroll bar and measure this end expiratory flow. If I see the end expiratory flow, say 40% of the peak expiratory flow, 40% is not enough. I needed 75% to make the alveoli stable. So I will decrease the T low. If it is 0.5, it will be 0.45 and 0.4, 0.35. I will keep decreasing until I reach the end expiratory flow, 75% of the peak expiratory flow. Okay? By experience, in this severe COVID ARDS, like our patient, you will start by 0.3 seconds. This will make the end expiratory flow from 60 to 70, 75. You will start by 0. You will not start by 0.5 seconds. You will start by 0.3 seconds. Okay. This is a cornerstone, because if you keep your patient, if you increase the T low and the expiratory flow go to near baseline, this is de-recruitment. Your patient will be in very bad shape because atlectotrauma. You are ventilated, you are distended and collapsing. This is very bad way. But please don't play with the T low. T low is fixed. 0.3, 0.4. Don't play with T low at all, whatever the ABG. Okay, because this is the cornerstone of the ABRV. This was the setting of our patient really in day 3. احنا we increase the T high to 3, the B high 30, will T low 0.4 second, will give 5 pressure support, will be low 0. And this is the way I look the screen, and I am measuring now the big expiratory flow is 54. You need this to 75% of this 54. It's very easy. Yani. You will look the screen and the measure by scroll bar this end, and you play with the T low until make it 75. If you make it 75, you are safe. This is the best way to stabilize, not recruit the alveoli, to stabilize the alveoli. Okay, this is very important point now. What we need from the ABRV is proper recruitment, not over distension. And second, we need spontaneous breathing in very appropriate pressure volume care. So I need to look to my patient. I need to look with my eye to my patient. I need to be sure from 2 things. No forced exhalation, because if the patient is over distended, he will force exhalation, and at the same time, if the patient is not in the proper pressure volume care, he will gasp, will suffer during spontaneous breath. And third part, you need to look for the abdominal breathing, because ABRV is dealing with diaphragm. So you will see a lot of abdominal breathing, not just wall breathing, a lot of abdominal breathing, okay? But calm abdominal breathing, not gasping. These 3 patients, I make a video to look for the way of breathing, because it's very important. If your patient is making forced exhalation or is gasping with accessory muscle, you need to rearrange things, and you may abort the ABRV because you are not fulfilling the criteria. The patient should smoothly breathe spontaneously, because we are not going to give muscle relaxant, we'll give light sedation. But that means the patient should breathe spontaneously, smoothly, and at the same time shouldn't be overdistended. Look for these three patients, please. Look for, this is the inhalation. Inhalation. And he's taking spontaneous breath at the end of peak. Inhalation. Inhalation, we release, okay? Look for this patient. Look for the abdomen. شوف inhalation, it's mainly abdomen. There is descent of the diaphragm. Mainly abdomen, not chest. The chest is not moving. Mainly abdomen, okay? Look for this calm breathing. This is our patient. This is our patient. Look for, it's very calm breath, no gasping at all. It's very important. Please look to your patient. It's very important. If your patient is gasping, stop ABRV. There is something wrong. Okay. Okay. Now I'm talking about rescue ABRV for a patient which is difficult to ventilate. But there is a study done for early application of the airway pressure release ventilation and to compare with the gold standard, which is low tidal volume ventilation. As you see in this study in the intensive care medicine, done on 138 patients. The conclusion was compared to low tidal volume ventilation, early application of ABRV in patients with ARDS, improve oxygenation and respiratory system compliance, decrease plateau pressure, reduce duration of post-mechanical ventilation and ICU stay. I am not here to, because I know not everyone has experience with ABRV. Please, I'm talking about rescue ABRV, but still the low tidal volume ventilation from the evidence-based point is still the gold standard. If your patient done well in low tidal volume ventilation, it's okay. I'm talking about rescue ABRV. And you will see this type of patient really. This is great site, Palmacret, with pioneer Josh, associate professors in USA. He mentioned in his site this couple of months back, we have considerable success with ABRV in our COVID patient. This allows us to support and extubate several patients successfully while avoiding paralysis, proning, sedation, inhaled pulmonary vasodilatation, ECMO. Patient typically can be weaned from 100% FiO2 to 50% FiO2 within 6 to 12 hours as slowly recruit. As such, ABRV may be economical mode because we'll don't give a lot of sedation. I know there is shortage of sedation, the muscle relaxant in most areas now. And also we limit the resources because to do prone position, you need 5 nurses with 5 PPE. And really prone position with lung ultrasound, we know now exactly which patient who will respond with to the prone position. Prone position, the ABRV will deviate the ventilation to the basal part, but it will recruit the basal area also. This happened. This is another randomized prospective trial in trauma journal.
Walid, 5 minutes, please.
Okay, thank you. So I'm finishing now. Okay.
No, you can still have 5 minutes.
لا don't خلاص, it's almost 5 minutes. Thank you a lot, Dr. Anna. In day 3, there is marked improved oxygenation and hemodynamic in our patient. Lung improved a lot, right lung aerated, we left the lung mostly aerated, and the ABG became an alkalotic side, and we started to decrease the P high and increase the T high. And as you see here, the heart is normal. I am not saying ABRV treats the stress obviously, but at least it relieves the stress and the heart functioning well. This is the lung water. There is very proper recruitment, and it was 22, now it is 11 over 30 lung water score, recruited a lot. And you see here, the kidneys, there is very good perfusion after improvement of cardiac function, and this negative pressure, this spontaneous breathing with sucking of blood and increasing venous return. And we can compare here between day 1 and day 2. Look for day 1, very bad ejection fraction. Day 3, very good ejection fraction. Look for X-ray in the day 1 and the day 3. Look for the kidney. This is the blood only in the hilum. Now the blood reach to the capsule of the kidney, as you see here. And this is very important graph here. If you, someone will say, you will give too much pressure and too long time, you will increase the resistance in front of the pulmonary, in the front of the right ventricle. You will increase the pulmonary vascular resistance and will make hemodynamic compromise. This is not the case, because there is two types of vessels. There is extra alveolar vessels and alveolar vessels. So pulmonary vascular resistance will be the lowest with functional residual capacity. With proper recruitment, the pulmonary vascular resistance will be the lowest value. But with over-distension, pulmonary vascular resistance increase, and with de-recruitment, pulmonary vascular resistance will decrease. So the lowest pulmonary vascular resistance will be in case of functional residual capacity, which means proper recruitment, neither over-distension nor collapse. So as you see in our patient, despite high pressure and long time, the heart is not affected. In contrast, it improved. We gradually decrease the P high with increasing T high, allowing the patient to increase. This is a way of weaning. It's very simple. We'll gradually decrease the P high, and increasing the T high makes the patient to do a lot of effort until we reach to 15 P high centimeter water and 6 to 8 seconds. In this situation, you can shift to CPAP pressure support. And this is what happened to our patient. We successfully extubate in day 5. And thank you a lot for your watching. Believe me, this is very important. Try it. It works because you need it in very bad time. And I hope all of you don't see this bad time a lot. Thank you a lot.
Thank you so much, Dr. Walid, for this interesting lecture. Our third lecturer for tonight is Dr. Ahmed Taha. He's a professor of anesthesia, Ain Shams University in Cairo. His lecture is going to be on brachial plexus block. Welcome, Dr. Ahmed.
Thank you so much. First, I'm very happy to give this lecture after Dr. Samir and Dr. Walid. Very nice lecture, really. Just a second. I think Dr. Walid have to stop. Okay. First. Bismillah ar-Rahman ar-Rahim. Bismillah ar-Rahim. Today, inshallah, we'll talk about the brachial plexus, which block I should perform. My objective is first we'll start talking about some anatomy of brachial plexus. We will discuss different kinds of brachial plexus block as the advantages of each approach and the drawbacks of them. And then we'll go for innervation and peripheral block for each region, for the clavicle, for shoulder, for arm and elbow, for forearm, and for the hand. And at the end of the any question. In the upper limb, thanks Allah subhanahu wa ta'ala, that in the upper limb is supplied by one plexus, not like lower limb, which is supplied by two plexus. So single injection is enough to provide anesthesia to the patient. This plexus, of course, is the brachial plexus. Thanks Allah also, that's brachial plexus, superficial plexus. So usually all upper limb blocks are simple and easy and causes less discomfort to the patient. For simplification, the brachial plexus start by 5 roots, and then roots change into trunks, where you give the interscalene block, then trunks giving divisions, then divisions go to the brachial plexus cord, and from cord, most branches is gone, branched from the level of the cords. As you see in this picture here, that's most of brachial plexus branches, about 14 branch coming out of the after distal to the cord level. However, there is one important branch coming from the upper trunk, which is a suprascapular nerve, which supply the shoulder. So all branches, or most of the important branches coming from brachial plexus coming after the cord, with exception of one important one is suprascapular nerve, which come from the upper trunk. Now we are going to speak about some the brachioplexus techniques, blocks, and their drawbacks and advantages. The first one is interscalene block. It's one of the very simple block and very successful block as well, where you block the trunks of brachioplexus. As you see here, this is the brachioplexus between the scalene muscle, and here's the sonographic appearance. You block this brachioplexus, and this is the interscalene, a very successful and very simple block. It's one of the advantages of interscalene that is local spread to superficial cervical plexus, which giving innervation to the skin of the upper shoulder and the clavicle as well. So in surgeries in these regions, this will be an advantage for interscalene to do this spread. However, it also spread to the sympathetic fibers and causes ptosis and Horner syndrome, and maybe to the recurrent laryngeal nerve, causing some change in the sound. However, it doesn't care, it just reassures the patient is not a big issue. The main issue with is the phrenic block. The phrenic block is very close, its relation to the brachioplexus is very close at this level. So the interscalene block result in phrenic block, and this result in mild hypoxia, which can be simply tolerated in most of patients. As we see here, this is the M-mode picture I showed yesterday to differentiate between pneumothorax and phrenic block. If you have a pneumothorax, you don't have this dot-like appearance of the M-mode. You just have lines. This meaning that the two layers of pleura is separated. The phrenic nerve occurs in almost 100% of interscalene block. And in our last study we published in ACTA, we find that even with 5 ml, the interscalene block result in phrenic nerve block in about 90 or more than 90% of patients. So as I said, it can be tolerated in most of patients, except in patients with limited respiratory function. These people will not tolerate such diaphragmatic block. Another problem with interscalene is the vertebral artery. That if you give the interscalene at level of the C7, usually the vertebral artery at this level is still not inside the transverse foramina. And so if a deep or very medial or very deep advancement in the needle injection inside the vertebral artery may go to the brain and causing convulsion. So this is, so as I said, the interscalene is very safe with the exception in the patient of the limited respiratory function. The second block here is a supraclavicular block, what is very famous as the spinal of the upper limb, where that's division of brachioplexus is surrounding the brachial artery, the subclavian artery. And I'm sorry, by mistake yesterday, I mentioned that this bone is the clavicle. Accurately, this bone is the first strip. I'm sorry for this mistake I mentioned yesterday. So this block is a very successful also block, and the brachioplexus is very superficial, so technically it is easy. However, it have a big problem, that is the lung is very, and the pleura is very close to the brachioplexus. And incidence of the pleural injury, it's maybe go to 10% in nerve stimulator landmark technique, and it's still happening even with the ultrasound. And at the same time, this block is also spread to the phrenic nerve, so it does not give me a big advantage over interscalene block. The next one is the costoclavicular block. It's a new block and know a lot of data about this block. It's midway between the supraclavicular and infraclavicular. As you see, just the subclavian artery here in the supraclavicular, the name is changed into axillary, and still the brachial plexus lying lateral to the vessel, but the probe is placed below the clavicle. No data about this block, and actually I don't use it a lot, so I don't have an opinion about this block, but it seems to me midway between the supraclavicular and infraclavicular. Now we are going for infraclavicular block. In the infraclavicular block, we block the brachial plexus cord cords around the second part of axillary. This is the axillary artery, and this is the cephalic part, and this is the caudal. And you can find this is the lateral cord, posterior cord, and medial cord, and this is axillary vein. In this situation, the artery lies deep to the two pectoralis muscle. Relative to the interscalene block, the infraclavicular does not block the phrenic in almost all cases. but it also does not block the suprascapular nerve. So alone, it cannot be used for shoulder surgery. Relative to the axillary block, the infraclavicular have less needle pass. So actually, it causes less discomfort to the patient than the axillary block. It also blocks the axillary nerve. So this nerve is not blocked in the axillary block. So this is a very funny. That axillary block does not block the axillary nerve. But this block, the infraclavicular block, has one disadvantage, that is the onset is delayed. Yani it's not that fast onset. And so in this block, I prefer to use a higher concentration of local anesthetic or add some short intermediate acting like lidocaine. Also, relatively, this is one of the deepest position of the precaplexus. So it is relatively deep than other precaplexus in the intrascalene or supraclavicular or axillary. All of this situation, the precaplexus is more superficial than this situation in the infraclavicular. The infraclavicular, the needle access to the precaplexus may be inserted inferior to this is the CT of the clavicle. This is a two pectoral muscle, and this is a vessel, the axillary vessel, and surrounded by precaplexus here. And this is the clavicle. In the classic approach, the needle is inserted inferior to the clavicle. In the retro or posterior approach, the needle inserted superior to the clavicle. And this kind of needle insertion superior to the clavicle and this technique make the needle is more or less more horizontal. And as we described yesterday, the more is horizontal the needle, the better is visualization. So actually in this retroclavicular approach, the needle visualization is better than the classic approach. Then the injection point. In the infraclavicular, it's a very famous study done by pioneers of regional anesthesia, that is they inject 40 ml of local anesthetic deep to the artery, what is known as double bubble sign. However, if you use less than this volume, the word block is not working. Instead, in our technique and our routine work, we inject just 10 ml of local anesthetic above the artery and 10 below the artery, and that's it. So we inject 20 ml only. So as you see, this is the local anesthetic surrounding the artery from above and from below, and this is the needle very clear. You will not achieve this clear needle in the classic approach. As we said, that is infraclavicular cannot block the shoulder because the lack of suprascapular nerve block. So if you add suprascapular nerve block, you can use it for shoulder. In this, we published this technique called the ISO block that is combined. We can combine both suprascapular block and infraclavicular block through one injection or one single puncture above the clavicle here. And we use the subomohyoid technique that I showed you yesterday for blocking the suprascapular nerve. Then we'll go to another technique for precaplexus with axillary nerve. It's very easy technique that's surrounding the branches of precaplexus, the median, ulnar, and radial surrounding the axillary artery, with the muscocutaneous nearby within the coracobrachialis muscle. The axillary nerve, as I told, axillary block, as I told, it does not block the axillary nerve. It still also need a long duration, so its onset is delayed. Lastly, the technique of the elbow block, where you separate these branches of precaplexus separately. We have three branches crossing the elbow, the median, ulnar, and radial, and some cutaneous branches, which is the medial cutaneous nerve of the forearm, the lateral cutaneous nerve of the forearm, and posterior cutaneous nerve of the forearm. The posterior cutaneous nerve of the forearm is the branch of radial, and the lateral cutaneous nerve of the forearm is the branch of muscocutaneous, while the medial cutaneous nerve of the forearm is the branch of the medial cord. In this image that you can see, this is the technique of median nerve block at the elbow. The nerve lie medial to the precaplexus. And here the ulnar nerve block, the nerve lies superficial to the medial supracondylar ridge. And then the radial nerve, its nerve lie anterior and superficial spot diagnosis in front of the humerus. Now we didn't solve the problem, which block I should perform. The choice of the block that you should perform is depend first on the regional site of the surgery, the regional innervation of this site regarding the skin innervation, the muscle innervation, and the bone innervation. because if the surgery is deep to the bone, and in most of orthopedic surgery, so the bone also should be blocked adequately if you use it as anesthesia. The second thing that affect my choice of a block is patient comorbidity versus the block risk. So if the patient have bleeding tendency, I will not prefer to give, for example, infraclavicular block. If the patient have COPD or a limited respiratory function or ischemic heart disease, I will not prefer to give intrascalene block. So the patient morbidity and the block risk is the second point. Then if the patient is healthy, and we may find that many blocks can cover same area. In this situation, my choice will depend on the simplicity of the technique and the block criteria. The more rapid onset, the more prolonged analgesic effect, and the less motor block post-operatively will be my first choice. We will go region by region to see the innovation and what is, to my belief, the best technique or the technique of choice in each region. First, we'll go to the clavicle. The clavicle, the bone of clavicle is supplied by two branches of the upper trunk, the suprascapular nerve and subclavius nerve, and both are branches of the upper trunk. While the skin overlying the clavicle is from superficial cervical plexus. As we said, that is intrascalene block can spread to this superficial cervical plexus, and it will block the upper trunk, so it can be used for anesthesia for ORF or clavicle. For analgesia, intrascalene block can be also used. Superficial cervical block will block the soft tissue above the clavicle, the skin, and subcutaneous tissue, and it will give a very good analgesia, really. And it may be also replaced by infiltration of local anesthetic above the clavicle. However, in superficial cervical plexus, in clinical part, it reduces phrenic nerve block as well. So it will not give you advantage over intrascalene block. Both of them will block the phrenic block. With exception that is intrascalene will keep the shoulder moving. So the patient can move the shoulder after surgery. This as analgesia, but for anesthesia, no other alternative than intrascalene block. The second is the shoulder surgery. In the shoulder, it's supplied by many branches of the brachial plexus cords. So if you give infraclavicular block, you'll block about 70 or 80% of the shoulder. But still there is one branch, as I said, it's the suprascapular nerve, which is not branch of the cord. It's coming from the upper trunk. So, and also there is, as you see the shoulder here, the skin is inflated by superficial cervical plexus. So the first choice as anesthetic or analgesic is intrascalene block. However, as you said, I'll not prefer intrascalene block if the patient have limited respiratory function. In this case, I will use isoblock, which is combined suprascapular block and infraclavicular block. And this will not block the skin, so I will add some local infiltration of the skin at the skin ports. As you see this video, this isoblock is used alone as an anesthetic agent for a patient for shoulder surgery. And this, as you see, that's been free introduction of the scope, and patient is going spontaneously with light sedation, midazolam. As you can see, the patient is spontaneously breathing, and there's some oxygen concentration. And even with a very tense bipolar use, this is acromioplasty, which is dependent on suprascapular nerve block. It's very patient. And this is after surgery. We are looking to the phrenic nerve movement. As you can see, the diaphragm is moving freely. So this isoblock can give you a wonderful anesthesia and reliable, but it's, as I said, it's only if the patient cannot tolerate intrascalene block. So as you see here, this is the liver, this is the kidney, and this white is the diaphragm. When the patient moves, the diaphragm pushes the liver and kidney downward, and so we see that the patient have a good diaphragmatic function. The next region is the arm and elbow. The arm is supplied by muscocutaneous nerve in the front of the anteriorly and the radial nerve. Also the axillary nerve, which is supplied by the deltoid muscle here, and the overlying skin and the underlying bone. So this axillary nerve is not blocked with the axis axillary block, so it cannot be used for upper arm surgery. The axillary block will not work for upper arm. And here in the arm, the only area in the upper limb not supplied by brachial plexus with this skin area, except just vascular graft, is occurred in the medial side of the arm. But most of the time, the surgery in the lateral side of the arm. So you don't want to block this nerve in most of time in upper limb surgery. So still, interscalene block is our first choice in arm and elbow surgery because, as I said, it's variable blocks of the patient. However, if the patient COPD or sensitive to phrenic block, we can use infraclavicular for upper arm, and axillary still can be used for lower arm and surgery. And axillary can be still used for lower arm and elbow. However, infraclavicular is better than axillary because less discomfort and more block and prolonged duration. And actually, it is easier than the axillary because in the axillary, you have to advance the needle for each branch. In the infraclavicular, you just inject above the artery and below the artery, and that's it. So it doesn't take time. In this video, we have still one patient with COPD, and we give her infraclavicular for Aureus of the humerus. Arm tourniquet. This is an important point. The arm tourniquet caused by ischemic pain of the muscle of the arm, mainly the anterior muscles, which is supplied by the muscocutaneous. So if you block the muscocutaneous, you will block the arm tourniquet. Alhamdulillah, all blocks, proximal blocks block the muscocutaneous. Interscalene block the muscocutaneous. Suprascapular block the muscocutaneous. Infraclavicular block the supraclavicular block the muscocutaneous. Infraclavicular block the muscocutaneous, and the axillary block the muscocutaneous. So all of them can tolerate the tourniquet. However, if you do elbow surgery, you have to block the muscocutaneous separately if you need to apply an arm tourniquet. One good point here that if the surgeon is cooperative, you can use a forearm tourniquet. Usually forearm tourniquet can be tolerated for 40 minutes without anesthesia in most of time. But if the surgeon insists on arm tourniquet and you need to give, and you like to give the elbow block, you have to block the muscocutaneous nerve separately. Then we'll go to the forearm and wrist. The forearm is supplied by 3 nerves. The muscle and bone of the forearm supplied by 3 nerves only. The the radial, ulnar, and median. The skin, the medial cutaneous and posterior cutaneous and lateral cutaneous supplied by medial and lateral and posterior cutaneous branches. The last 2 is branches of the muscocutaneous, which you'll block for the tourniquet, and the posterior coming from radial, you can block it in the spiral groove as I showed you yesterday. But the medial cutaneous nerve, if the surgery in the medial side of the forearm, you have to block it as well. The medial cutaneous nerve, I showed yesterday. The problem with the elbow block, it is the number of the injections. So that's why, although the elbow block have a fast onset and the technique is very simple, but the number of needle insertion make it in the last choice if you do a forearm surgery. Still, the first choice is infraclavicular. Infraclavicular block all innervation to the forearm. Axillary still can block it, but as we said, the infraclavicular is superior to the axillary if there is no contraindication. And last, you will do elbow block for forearm surgery. Only the advantage of the elbow block is the fast onset, and it keeps the movement of the shoulder and the elbow. It does not affect both. So the patient can move his hand and no need for arm sling if you use the elbow block. But the disadvantage is the number of injection, which may cause some discomfort. In this surgery, we did a forearm surgery with infraclavicular also. Infraclavicular really is a very good block and very successful. Lastly, the hand surgery. The hand is entirely supplied by 3 nerves, the median, ulnar, and radial. The skin, the muscle, the bone, everything is supplied by these 3 nerves. So simply elbow block is enough. Characteristically, that the medial side of the hand is entirely, and this is the only position in the entire body, that the skin, muscle, and bone supplied by 1 nerve, which is the ulnar. This is unique. You'll never find such thing in the whole body, that the skin, muscle, and bone supplied by the same nerve It's only in this little finger. So if you have a surgery in little finger, it's simply you can block the ulnar nerve alone, and it will be enough. If the surgery in the ring, is a surgery in the finger, you can give ring block. It will be enough. But otherwise, you have to give the 3 nerves: ulnar, median, and radial. So if you have a surgery here in the hand, anywhere in the hand except in the medial side, you will give the 3 nerves: ulnar, median, and radial. And still, if you will add the arm tourniquet, you have to give muscocutaneous as well. In this surgery, as you see, that patient have the elbow block, and he can do upper arm hand surgery in very smooth way. So to summarize, the interscalene block can cover the clavicle, the shoulder, the arm, and the elbow, and it will be the first choice. The infraclavicular will be the first choice, but note that interscalene does not block the ulnar side, so we cannot use it, or it's not good to be used distal to the elbow. So if the surgery is distal to the elbow, if the forearm, I will prefer to use the infraclavicular block. It block all innervation of forearm. It's easy block and simple. If the surgery in the distal, in the proximal part of the hand, I prefer to give the elbow block. Elbow block give me advantage that the patient can, there is no block in the shoulder, there is no block in the elbow, the patient can use both. If the surgery in the finger, we can give the ring block. This is the first choice. If the patient have contraindication, there is no contraindication for, I don't think there is no contraindication for ring or elbow block. If the infraclavicular is risky, as in patient with bleeding tendency, some people prefer to give the axillary because infraclavicular is relatively deeper than the axillary, or elbow block still can be used in forearm surgery. In the arm surgery, if the patient have problem with phrenic nerve block, so we'll avoid the interscalene, so we can use the infraclavicular for arm surgery, isoblock for hands, for shoulder surgery. And for clavicle, if we will not give interscalene, we should give only infiltration to minimize the risk of phrenic. However, it will be analgesic, not anesthetic. Thank you so much, and I hope it was clear lecture.
Thank you so much, Dr. Ahmed, for the very good presentation. Now, I think we have some time for just a few questions and answers, please, from the lecture. First question to Dr. Ansari, Professor Ansari, about the dose adjustment of vancomycin in patients with renal failure and end-stage renal disease on RRT therapy. Is Professor Ansari with us?
Yes. As you know, renal failure patients may be subjected to either traditional hemodialysis or CRT. If the patient on CRT, we can give 15 to 20 milligram per kg per 24 hours. If your patient on traditional hemodialysis, you can give according, of course, to creatinine clearance. And in any patient with renal impairment, you have to monitor the creatinine, monitor the vancomycin level. You have to monitor vancomycin level before every or after every session, after the session by 4 hours, and then give your dose. And consider that any hemodialysis, every 2.5 or 3 hours dialysis will take all or will remove about 20% of vancomycin dose. And so you have to adjust the dose in your patient according to creatinine clearance. Suppose your patient accepting creatinine clearance less than 15, you have to give this dose 10 to 15 milligram per kg per 40 hours. Per 40. If your patient on CRT, 10 to 15 milligram every 24 hours.
Another question is about triple antibiotics therapy in ICU. They ask, is it still in practice or is it obsolete now?
No, I said no. We can use double antibiotic therapy in cases of empirical treatment or in cases of severe infections. And as soon as possible, try to de-escalate your antibiotics to the target.
Thank you so much. Thank you, Professor Ansari. The first question to Dr. Walid is about you mentioned the dose of epinephrine, 5 microgram per minute.
Norepinephrine.
Yes, you said 5 microgram per minute. Do you titrate it according to the body weight or?
Really, norepinephrine dose, we can reach to 1.5 microgram per kg. But for our patient, he was fluid responsiveness because he has grade 1 diastolic function, normal left atrial pressure, and collapsing inferior vena cava. For this patient, he needed very minimal dose, 5 mic per minute, because we give fluid challenge and the patient improve. We can give empirical 5 mic and titrate it, and we can give 0.1 to 1.5 to 2 microgram per kg in severe sepsis. But you can give small doses.
Another question about the sedation. What about the sedation during APRV?
This is very important questions.
Use deep sedation or light sedation?
RAS scale -1, -2, great. RAS scale -1, great. We don't need any muscle relaxant. We need the patient to breathe spontaneously and calm. Once the patient is breathing without difficulty, he can just -1, -2 with small dose fentanyl, only fentanyl, it's great. We don't need too much, and this is one of important advantage for APRV.
Okay, our third question is, what is the difference between BiPAP and conventional APRV?
Really BiPAP, you will make the below at 5 centimeters. You will, some people make the below 5 centimeter water with the B high 30. But this is BiPAP, but this is not the way at all. It's not. It is forbidden to do it nowadays. Nowadays, B low is 0 because this was the cause of CO2 retention. We are recruited by auto beam and by volume, not by pressure. For BiPAP to make 2 pressure, it is forbidden at all. We now, any center running APRV, below is 0, no more.
What's your acceptable peak value in APRV?
Very important. Usually range 15 to 16, but the recruitment and stabilization of alveoli in APRV better than beep 24. To try to reach near the stabilization and recruit of alveoli by conventional ventilation, you need beep 24. But the beep in APRV beep around 15 centimeter water.
Thank you so much, Dr. Walid. There might be more question added after this. So if you kindly look at them and then provide the answer, we would be very grateful to you. Thank you so much. Question to Dr. Ahmed.
Yes.
They asking, are all types of nerve block contraindicated if the patient is already on antiplatelets, or does it depend on the type or the approach of the block?
First, in patient with an antiplatelet, he will have a bleeding in the surgery. So the surgery itself is more dangerous to the patient than my needle. So this is the first point. In most of societies, they equalize nerve block with neuroaxial anesthesia. So usually they use the same protocol for coagulation as doing spinal and epidural. And actually, this is not fair, because the point in spinal, it is closed space, and bleeding inside will increase the pressure too much, causing ischemia of the cord. But this is not the case in the peripheral nerve. In peripheral nerve, the tissues is more expandable, and so small hematoma will not causing nerve damage. Only very big hematoma can create enough pressure to damage the nerve. So first of all, if the patient can tolerate general anesthesia and it's safe to do the general anesthesia, so I consider nerve block is relative contraindication. So if the patient can tolerate general anesthesia with no risk, the patient doesn't have a problem with general anesthesia, okay, so general anesthesia will be enough. But most of the time, the patient have ischemic heart disease and he has very vulnerable hemodynamics. So in this case, you can use nerve block if you are expert, and just avoid deep blocks. Deep blocks like deep lumbar block, paravertebral block, deep lumbar plexus block. But in brachial plexus, it's very safe. I think if you are expert, you can do it without problem. It just needle 21 or 22 gauge. So you can still need it, and to avoid the complication general anesthesia. But as I told you, the problem will be the knife of the surgeon. It will cause more hematoma and more nerve damage than my needle if you are doing the case without stopping the antiplatelet for proper time.
Yeah. So another question is about the hand surgery. Which is better, brachial plexus block or Behr's block, in your opinion?
No, Behr's block does not give you post-operative analgesia. Behr's block is risk of toxicity with the problem of tourniquet. Behr's block is problem with prolonged hand surgery. In some time of hand surgery, it may take 2 hours or more. So Behr's block, actually, it's not a block. It's just a very, very, يعني nerve block is far quality of analgesia, post-operative and intraoperative is far better than nerve block. But unfortunately, Behr's, it's cheaper. You just need an IV line. You don't need any equipment. You don't need nerve stimulator. You don't need ultrasound. So it's cheaper if you don't have equipment. But once you have equipment, there is no comparison.
It's potentially more dangerous, and if you're not careful. So, they ask about the tourniquet. What if you're using the tourniquet? What kind of block would you?
As I mentioned, that is tourniquet. For tourniquet pain, for usual duration, it's only due to muscle pain or muscle ischemia. And if it's within 2 hours, it can be covered by muscocutaneous block. Any block proximal to the axillary, including axillary, will block the muscocutaneous. If you do elbow block and tourniquet, arm tourniquet will be used, you have to add muscocutaneous. If the surgeon is cooperative and he apply instead of arm forearm tourniquet, no need to do anything. It will be can be tolerated even without anesthesia.
Thank you so much. Again, plenty of we don't have much time for them. So if you can answer them later for our candidates or attendees, that would be very much appreciated. Thank you so much for the lovely, interesting.
Thank you very much.
Thank you so much.
That's extremely rich webinar, and thank you much for all attendees and all professors. And thank you, Dr. Adil, for guest visitor tonight, and all Professor Samir, Prof. Ahmed, Dr. Adil, and thank you very much for our distinguished moderator tonight, Dr. Nahla Awad, and
My pleasure.
everybody here. And thank you. Hopefully, we'll see you again. Thank you very much.
Thank you.
Thank you.
Bye.
Mr. Dara Walsh, thank you very much.